Good evening. How is everybody? I'm really so delighted tonight to have Dr. Safaa, Hamid, one of our guests, to talk about cardiac manifestation in COVID. And probably we have touched on this topic before, but in this occasion, we are going to go deeper and we are going to encompass all the new evidence that has accumulated over time about COVID and the heart. So, Dr. Safaa, the floor is yours. You can take, the screen is already clear, and now the mic is yours, so you can start.
Right. Thank you, Hatim, for having me today to discuss this important issue, the COVID-19 and cardiovascular disease. So first of all, we need to know what is a coronavirus. COVID-19 is a disease which is caused by SARS-CoV-2. It's RNA virus. It has 4 or 5 structural proteins. The spikes protein, the S1, is mediate receptor binding. The membrane protein assists viral assembly. And also we have a nucleoside protein, which is regulating the viral RNA synthesis. The envelope protein, it's not fully understood yet, its function, and that's all the proteins in the COVID-19 viral or SARS-CoV-2. So this virus primarily affects the lung, but it has many effects on the heart, and that's what we're gonna discuss today. So how does the COVID-19 affect the heart, and what is the mechanism of cardiac injury? The heart can be injured due to hypoxia caused by severe lung infection. Also, the virus can injure the heart directly by causing myocarditis. Also, the heart can be triggered, the virus can trigger arrhythmia as well. It also can trigger the blood clots, leading to some clots in the arteries and vein as well. The virus can also trigger something called cytokine storm. It's immune response reaction. In this, the body begins to attack its own cell and tissue instead of fighting the virus. That can indirectly damage the heart and other organs as well, causing multi-organ failure in the severe COVID-19 infection. Also, the patients with underlying cardiovascular disease, as well as those who are having comorbidities like diabetes mellitus, hypertension, or obesity, are having greater risk and more likely to die or to get severe infection from COVID-19 if they do become infected. Patients with mild form of the disease usually can be managed at home by keeping in touch with their doctors, but some struggling to breathe or having shortness of breathing, those kind of patients need to come to the hospital to get supportive care. We realize that many of those patients have a very wide spectrum of cardiac involvements, ranging from mild symptoms of mild cardiac affection to severe one. The most common acute presentation is acute coronary syndrome, whether it's STEMI or non-STEMI. It's commonly occur in elderly patients with underlying coronary artery disease or acute thrombotic occlusion due to COVID-19 infection. However, there is another group of patients who have a similar presentation of acute coronary syndrome. They are presenting with typical chest pain like that happened with acute coronary syndrome, but on coronary angiography, there is no thrombus formation. And that can be due to microvascular disease or stress-related cardiomyopathy, or sometimes could be due to myocarditis. Separate but related can be arrhythmia, whether atrial or ventricular arrhythmia, that can happen secondary to hypoxia. Also, intrinsic lung disease related to the virus or thromboembolic phenomena can also trigger arrhythmia, or some medication that we have been proposed as a treatment of COVID-19 have pro-arrhythmic effect. Also, patient can present with acute thromboembolic complication like DVT or pulmonary embolism. Virus also can lead to heart failure. Sometimes patient can get pericardial effusion with or without tamponade. We know it's not common presentation, but we have seen some cases reported. This is my particular area of interest. I'm gonna talk in detail about this in the coming slides. We will start with acute coronary syndrome. The mechanism of underlying COVID-19 and the induced acute coronary syndrome may involve plaque rupture, coronary spasm, or microthrombi owing to systemic inflammation or cytokine storm. Activated macrophages secrete collagenase that degrade collagen, which is a major constituent of the fibrous cap on atherosclerotic plaque, which can lead to plaque rupture. Also, activated macrophages it's known to secrete tissue factors, which is a potent procoagulant that triggers thrombus formation when the plaque ruptures. Also, the direct endothelial or vascular injury caused by the virus might also increase the risk of thrombus formation and acute coronary syndrome. So the most important thing is to have a good plan in place. It's very helpful in diagnosing acute coronary syndrome in patients with COVID-19. Also, we noted that troponin is elevated in a lot of patients with COVID-19 in addition to the other biomarker. That's why it's very important to have a good plan and not to rely on only one finding. We need to take good history, to check the vital sign, the lab data, together with another investigation like ECG and echocardiogram, also to point a decision, is this patient needs to go to cath lab or only need medical treatment. That means not every elevated troponin means acute coronary syndrome. The myocarditis and myocardial injury, as evidenced by elevated TROP-T or other cardiac biomarker, the CMR finding and ECG finding as well. Unfortunately, among all cardiovascular manifestations, myocarditis has independently associated with high mortality rate among patients with COVID-19 infection. The other predictors of myocardial injury include the elderly patients, patients with advanced age, presence of comorbidities, and the elevated CRP. Here I will go through a recent study published by JAMA Cardiology on the outcomes of cardiac MRI in patients recently recovered from COVID-19. The objectives of this study is to evaluate the presence of myocardial injury in unselected patients recently recovered from COVID-19, and the design, the settings, and participants of this study. In this prospective observation study, they have chosen 100 patients who are recently recovered from COVID-19 illness, identified from the hospital Frankfurt, the COVID-19 registry between April and June 2020. The main outcomes and the measures of this study, its demographic characteristic, the cardiac biomarkers, the cardiovascular, the CMR finding also were obtained. The comparison were made with age match and sex match control groups of healthy volunteer, about 50, and the risk factor match patient, about 57 patients. So what are the results of this study? I'm going to summarize this table in simple points. So of these 100 included patients in this study, 53% were male, and the mean age was 49 years. The median time interval between the COVID-19 diagnosis and CMR finding was 71 days. Of the 100 patients recently recovered from COVID-19, 67% recovered at home, while 33 required hospitalization. At the time of CMR, high sensitivity TROP-T or troponin was detected. It was greater than 3 picogram per ml in 71% of patients, and significantly elevated in 3%, in 5% of patients. Patient recently recovered from COVID-19 had lower left ventricular ejection fraction, higher left ventricular volume, and raised native T1 and T2. So a total of 78% of patients recently recovered from COVID-19 had abnormal CMR finding. There was a small but significant difference between patients who resolved from COVID-19 at home versus in the hospital. Also, endomyocardial biopsy have been taken in patients with severe finding. It was revealed active lymphocytic inflammation. So the conclusions and relevance in this study, CMR revealed cardiac involvement in 78% of patients and ongoing myocardial inflammation in 60% of patients. That independent of pre-existing conditions, severity, and overall causes of the acute illness and time from the original diagnosis. This finding indicates the need for ongoing investigation of the long-term cardiovascular consequences of COVID-19. A finding on autopsy have revealed the presence of inflammation and viral RNA, and also there was marked increase in macrophages infiltration. The heart failure. In the early study from Wuhan, 799 patients' heart failure was one of the most commonly observed complications. They found that the heart failure is one of the most commonly observed complications of COVID-19, with reported incidence of 24% of all patients and 49% in patients who died. In the advanced stage of COVID-19, the response of the immune system to infection might trigger the development of stress-induced cardiomyopathy, as we mentioned before, or cytokine-related myocardial dysfunction, as with sepsis-associated cardiac dysfunction. Elevated pro-PMP also were identified in 49% of all patients, 85% of those who died. Acute myocardial injury and acute coronary syndrome triggered by COVID-19 can also aggravate pre-existing heart disease or provoke contractile dysfunction. Arrhythmia and sudden cardiac death. Also, arrhythmia and sudden cardiac death are common manifestation of COVID-19. The palpitations have been reported to be the main presenting symptoms in patients with COVID-19, even without fever or cough. Those with elevated TROP-T, they found to have to develop malignant kind of arrhythmia like ventricular tachycardia or VF than those with normal level of TROP-T. In hospital and out hospital, sudden cardiac deaths also have been reported in patients with COVID-19. The arrhythmia can be triggered also by myocardial injury or other systemic causes like fever, sepsis, hypoxia, and electrolyte abnormalities. Patients with advanced COVID-19 are often treated with antiviral medication and antibiotic that are known to induce arrhythmia in some patients. And some of these medications have pro-arrhythmic effect. The coagulation abnormalities and thrombosis. The clinical observation of the increased thromboembolic event in patients with COVID-19 suggests the presence of hypercoagulable state. The venous thromboembolism, or DVT, or pulmonary embolism is a common complication, especially in patients or admitted in ICUs. The mechanism of this coagulation abnormality, particularly hypercoagulation in the setting of COVID-19, is still now unclear. One hypothesis is that the severe inflammatory response and endothelial damage induced by COVID-19 in combination with underlying comorbidity might predispose patients to hypercoagulable state. Angiotensin converting enzyme 2 and cardiovascular manifestation and the effect of the renin-angiotensin-aldosterone system inhibitors on COVID-19. Given that the ACE inhibitor 2, or just let's say S2 receptor for SARS-CoV, the clinician and also patients are concerned about the safety of the ACE1 or as ACE inhibitor, or ARBs in the context of COVID-19. That's what I'm going to explain in this picture. So in renin-angiotensin-aldosterone system, angiotensin 1 converted to angiotensin 2 by ACE or angiotensin converting enzyme. The angiotensin 2 is degraded by ACE2 into angiotensin 1,7. So this angiotensin converting enzyme inhibitors block the effect of ACE and reduce the conversion of angiotensin 1 to angiotensin 2. ACE inhibitor has no direct effect on the activity of ACE2. With lower level of angiotensin 2, people take in patients who are taking the ACE inhibitor, it has been hypothesized that ACE2 might become overexpressed on the cell surface to bind to any circulating angiotensin 2 and then convert it to angiotensin 1,7. Researchers measured angiotensin 1,7 level on people taking the ACE inhibitor to detect increased ACE2 expression and function. It found that there is no evidence that the administration or use of ACE inhibitor increase the expression or function of angiotensin converting enzyme 2. So what are the recommendations? The recommendation, these renin-angiotensin-aldosterone system inhibitors have a great role in protecting the kidney and the myocardium, and withdrawing this medication may result in progressive decline in the clinical status, which cause clinical decompensation in patients with COVID-19. So this medication completely safe in patients with COVID-19 infection. Here also this picture explains the bidirectional interaction between the cardiovascular disease and COVID-19. The underlying comorbidities like hypertension, coronary heart disease, diabetes mellitus, obesity as well has direct proportional effect on the susceptibility and the severity of the COVID-19 infection, as well as the cardiovascular complication. In this also, it's here also it's explained that this medication, the common cardiovascular drug like ACE inhibitor or ARPS, has no effect or has no association between this medication and the susceptibility and severity of COVID-19 infection. So testing and diagnostic platforms. The patient should have complete clinical examination, physical examination performed by a physician. We need to select these laboratory tests carefully. A careful selected menu of diagnostic study to determine the status of cardiac and vascular health could also be performed as clinically indicated. Here is the set of the cardiovascular clinic blood and urine test. Sorry, CRP, D-dimer. Also, we are using the von Willebrand factor, antigen, and activity as well. Interleukin 6, the complete blood count with differential, sorry. Sorry. The complete blood count with differential, the basic metabolic profile. I have severe cold, that's why, sorry. Urinalysis, the anticardiolipin antibody, and ferritin. Here, the cardiovascular clinic diagnostic menu. You can stop recording for a while, Hatim, sorry.
Sure, we can. No problem. You can have your time while I'm going to discuss some few points you have mentioned. So actually, Dr. Safaa has given us a lot of points to discuss, and that the myocardial injury can be direct and indirect. And like Dr. Safaa has described, that the direct injury is due to the direct invasion of the virus into the myocardium. And the indirect injuries is because of a multitude of factors, including the hypoxia, the oxygen supply mismatch, the metabolic derangement, the systemic inflammatory response, the coagulopathy milieu created by the virus, and the cytokine storm. Another important point is that there are so many cases reported of MINOCA, myocardial infarction with non-obstructive coronary arteries, okay? And the hypothesis is that these cases might be due to myocarditis masquerading as ST segment elevation, microvascularly induced ST segment elevation, or because of stress-induced Takotsubo cardiomyopathy. And these special cases are really troublesome to the physician, because if I am confronted with a patient of COVID and ST segment elevation, I'm gonna assume they were still proven otherwise. So I'm gonna roll this patient to the cath lab. So is there anything that I can do to make me be sure about which type of ST segment elevation I am dealing with? Is it the ST segment elevation of obstructive coronary artery, and therefore opening the artery is essential and timely, has to be done, or this is MINOCA? So unfortunately, there is no way you can be so sure. But again, the role of echo is so important. Yeah, we have seen many cases of ST segment elevation in ECG, and when we do echo, we find that the echo is normal or manifesting global mild LV dysfunction or this kind of stuff. In this case, that will tilt the balance towards MINOCA or myocarditis, I would say, rather than STEMI. Because if you have ST segment elevation in the ECG, that would definitely mean if it's myocardial infarction, STEMI, the echo has to be abnormal and has to manifest regional wall motion abnormalities. So in the absence of regional wall motion abnormality in the echoes, but ST segment elevation in the ECG, the diagnosis is most likely myocarditis rather than through STEMI. And you might slow down here and you don't have to rush your patient to the cath lab. But again, you know, the cases we are confronted with, ST segment elevation cases, we usually don't think twice to take the patient to the cath lab and fix his coronaries. And that's why initially we were seeing many cases of normal coronaries, and we assumed that they were STEMI. And probably it is safe to err on the side of caution, and it is safe sometimes to overdiagnose. But the accumulation of evidence with the use of echo, again, does not add a lot to refine our diagnostic in this special kind of clinical challenging circumstances. I'm hopeful that in the future, and as we know more and more about COVID, we can sort out which type of STEMI or ST segment elevation in the ECG you are actually having with patient of COVID. So this is an important point Dr. Safaa has alluded to. The other thing is that, and the workup, I think Dr. Safaa was starting to tell us about the workup in terms of laboratory panel, in terms of clinical data and other diagnostics. So if you are ready, Safaa, to carry on, I'm ready.
All right, okay, thank you, Hatim. Sorry again. So I started with the cardiovascular blood and urine test. We are using CRP as an inflammatory marker, also D-dimer, the von Willebrand factor with antigen and activity. Studies have shown this von Willebrand factor. Patient with COVID-19 has significantly elevated level of von Willebrand factor, antigen and activity as well. It's likely contributing to the increased increased risk of thrombosis in patients with high von Willebrand factor, correlated with worse prognosis as well. Also, we are using the interleukin 6. Patient with hypoxia also had significantly elevated concentration of interleukin 6, complete blood count and differential as well. We use basic metabolic profile, urinalysis, protein and active sediment also, There's direct relation between the severity of COVID-19 infection and the development of AKI. The anticardiolipin antibody screening it's also associated with more severe disease regardless of the COVID-19 status. Ferritin as a key mediator of the immune dysregulation as well. Ferritin also was significantly elevated in severe patients compared with non-severe infection, and also associated with poor prognosis. Here, the cardiovascular clinic diagnostic, I think that's what we discussed, Hatim. The ECG finding, the echocardiogram with this strain evaluation, the PET CT scan, the MRI, the preferred way for evaluating of suspecting myocarditis, 24-hour Holter monitor, and the heart rate variability test, and pulmonary CT angiography. So before that, at the end of this workup, patients should receive a COVID-19 cardiovascular report, summarize the finding of each recommended test, instruction for follow-up as well needed, all the treatment as indicated according to the best available evidence. So COVID-19 vaccine information for heart patient. Here I'm going to discuss the commonly asked questions by our patients regarding the COVID-19 vaccine. The first one, are all heart patients advised to receive the vaccine? Yes, it's important that all patients with cardiovascular condition receive COVID-19 vaccines. Of course, we need to tell our patient also, of course, the vaccine does not necessarily prevent the people from getting the infection, but it will reduce the likelihood of serious illness, which may require hospital admission. The second question, what is the impact of the vaccine on those who have underlying cardiac condition? The COVID-19 vaccines trial included patients with heart disease and did not demonstrate any serious effects from the vaccine in such patients. The third one, are there any known interaction of the vaccine with heart medication? There are no reported interaction between the vaccine and heart medication. It is essential that heart medication are not omitted prior to or after the vaccine. The best intervention or the best prevention way here is trying not to get the infection from the start. We need to inform our patient to follow the social distancing, hand washing measures, trying to stay in a good cardiovascular health by getting a regular sleep, good nutrition, regular physical exercise, and avoiding all unhealthy habits like smoking or drinking alcohol. This is the best way to get the infection from the start. Thank you, Hatim, and I stay safe.
Thank you so much, Dr. Safaa. That was really brilliant. And just a few points to add. In the workup of COVID-19, because COVID-19 is kind of multisystemic, and we have a lot of complexities around the diagnostics and understandably around the management itself. What concerns us in cardiology is the utility of troponin. Now, troponin, in some hospital, there is a kind of tsunami, so it's used indiscriminately for all patients. And we are confronted with so many challenges to sort out this kind of subtle elevation in high sensitivity troponin. In COVID infection, like Dr. Safaa has mentioned, troponin is part and parcel of the workup for patients who are hospitalized, and especially for patients who are of serious infection and admitted to intensive care units. So I think troponin should always be requested. Here, troponin provide a prognostic measure along with some other prognostic measures. It is so prognostic because it has been found that patients who leak troponin are having more serious infection and more likely to die. Now, the problem is the involvement of a cardiologist in the interpretation of this high troponin, because we have mentioned so many times in this platform that troponin itself always comes from the heart, but it comes from the heart as ischemic injury or non-ischemic injury is so important to decide, because if troponin is elevated due to ischemic insult, then coronary angio is probably the way to go. But if it's non-ischemic injury due to the sepsis, due to the hypoxia, due to the myocarditis, due to the metabolic derangement, and all these stuff, then coronary angio is not the way to go, and you are gonna deal with the root causes. So how can we sort out that this elevated troponin belongs to ischemic injury versus non-ischemic injury? Things are not always easy. Dr. Safaa, like he showed us here, that we should always be integrative in our analysis, and we should include together clinical data, ECG data, marker data, chemical data, along with imaging data. But from our experience, and we are actually a center that is accepting and seeing so many patients of COVID, the troponin tend to be kind of flat trend. So the trend of troponin is not like in ischemia. In ischemia, usually the troponin is rising up, sometimes exponentially, but there is a trend of uprise. Usually in myocarditis and in non-ischemic injuries, and in COVID, when it's non-ischemic injury to the heart, troponin tend to be elevated, but it remains of flat trend, more or less. The other thing is that the echo is going to be also of help here, because is echo going to reveal regional wall motion abnormalities or normal LV function or subtle LV global dysfunction? So you could contextualize the echo in, the troponin elevation in terms of the imaging data together to tell which type of elevation are you dealing with. Echo isn't as well easy. You cannot just push the machine to all patients and do echo, provided the precautions in contact and stuff like that. And that's why the advice by all authorities, including ours, is just to do focus, which is point of care ultrasound, and you focus on the essential points in echo. So I'm not going to do a full study of echo, all measures, PW and CW, and assessment of the valve and interrogation of this and that. I'm going to focus on the LV function in particular. Okay, so that's going to be revealing, and it gives insight about what type of troponin elevation we are dealing with. Now, the study that is shown by Dr. Safaa, which I consider one of the essential input in COVID and the heart, is the German study by Valentin and Pumpman et al., which included 100 patients, and at least 60% of these patients showed evidence of myocarditis in CMR. Now, this actually sets so many questions. The criticism that goes for this study is that it was, patients were basically having moderate to serious patients. So it's not all patients of COVID, they will have this much of incidence of myocarditis. So it is not representative of the global sample of COVID patient across their entire spectrum of disease presentation and grade of their infection. The other thing is that there are further autopsy studies that fail to substantiate this high incidence of myocarditis. They found that myocarditis is not as high as proposed by the study of Valentina. But I still consider that we should be waiting for further evidence regarding myocarditis and COVID. And this study is just one slim light in the way. The other question that this study is going to stimulate is if the incidence of myocarditis is like 60% in patients of COVID, then will this myocarditis be inconsequential clinically, or it will have a chronic effect? That's a serious question we need to answer. Because now we stumble into myocarditis in asymptomatic patients brought back to do CMR for just academic research, okay? But how much are these patients with evidence of myocarditis are going to be affected in the future, knowing that they have evidence of myocarditis, though they are asymptomatic now? So this is a pressing question, and the jury is still out to answer about it. There are some cases we have seen, and there are anecdotal evidence of cases of isolated RV cardiomyopathy. So the RV is affected in isolation, and there are some cases of RV thrombus formation. So a thrombus are found in the RV cavity. Now, this kind of isolated RV cardiomyopathy, is it due to a direct toxic effect of the virus, or due to indirect injury, or due to the lung affecting the right side of the heart through pulmonary hypertension? These are all hypotheses, and we are not sure what is it, the exact mechanism, but we know for sure that RV cardiomyopathy is one of the manifestation of COVID. One last thing, probably the long haul COVID or long COVID-19. And because now we are seeing so many patients who fortunately recover from COVID, but they remain symptomatic for months. And their symptoms are usually shortness of breath and palpitation. And palpitation basically tends to be POTS, which is postural orthostatic tachycardia syndrome. And again, these things needs to be addressed by, trying to formulate clinical studies and see exactly the incidence of POTS and these type of palpitation. What are they? Because we know, unlike Dr. Safaa has showed us, that arrhythmia is part of the presentation of COVID infection during its acute stage. But what about the chronic stage? What about after the recovery? Do we still have palpitation? And does this palpitation mean anything serious in terms of arrhythmia? Are we doing Holter for these patients and see exactly what type of arrhythmia is going to be disclosed? So these are all questions. So we are still in the process of learning. And I think this learning process of COVID is not going to come to an end anytime soon, because the evidence is accumulating per the day. Last, I would like to ask Dr. Safaa if she needs to comment or add anything to that.
No, I think it's more than enough, Hatim.
Okay, great. So I would express my deepest gratitude to Dr. Safaa for this brilliant talk about COVID in the heart. And I think we covered the major aspects. And thank you so much, Dr. Safaa. And that was really a brilliant talk. And hopefully we are going to get you back in this platform with a different topic. And thank you, all of you. And thank you so much.
Yeah, Hatim. Thank you so much.
Thanks a lot.